Thank you very much for joining this CPD meeting in the Johannesburg Department of Family Medicine. It's an opportunity for us to be able to explain to clinicians on the ground how the plan for Johannesburg works in terms of dealing with the COVID pandemic. So I'm going to go through a plan that was developed over the last 2 weeks that was signed off a few days ago by the Chief Director, and that is expected to be implemented in all clinics across the Johannesburg Health District. This is provincial side. Their local government have got a similar plan, but it would be important for you to understand the provincial plan. Most doctors, clinicians are actually in provincial clinics, and we are hoping strongly that you as a clinician can in fact make the difference. So I hope that you will look at this plan carefully, not just with a view that you as a clinician know it, but that you reach out to your clinic manager or CHC manager and ask them how they're doing with this plan, where their difficulties lie, how might you help them implement it. And I think making sure that the way it is being implemented is based on the intentions that we have, that patients are, you might say, contained to an area that will not have contamination across the entire clinic, and also that patients are being managed well, and that one has a good triage system that will pick up exactly which patient needs to be suspected as COVID-19 and which potentially is a patient that needs to be managed for referrals to hospitals. So let me just say thank you. We have about 42 attendees, and I can see a number of people that are both from within the Department of Family Medicine, but outside of it. Welcome to all of you, and I hope that you find this orientation to the plan a useful one. With regards to, let me just find the document. You are seeing the document in front of you, and in terms of taking this forward, we basically have said that we need to plan the intervention using the NICD guidelines, but looking at 3 areas within our ambit of work. One is to be able to reach out very clearly to the community from a facility level. So I think that one of the little concerns that have been raised is our link to the public health interventions. We are not, as family physicians, responsible for that, but we link it up. So I think this is about how primary health care is in fact managing this process. Give me 1 sec. So there are 3 avenues. One at a facility level, how do we reach out to the community? Secondly, what do we do in the facility itself? And then being sub-district managers, trying to deal with what goes on to support these facilities, there's a sub-district set of tasks. So in summary, and I'm going to go through this in more detail, in summary, basically, there are these 3 interventions, and the key elements of it are to be able to ensure that the community stakeholders are involved, that we've deployed community health workers, and there's a clear, consistent message. The second thing is that in the facility itself, the key elements is that we want a triage area that will be at the facility gate that will prioritize patients with flu symptoms. We also have set up then a temporary chest clinic, which we're saying to these patients with flu symptoms, those that need to be actually managed, we direct them to that chest clinic as a part from the broader clinic, so that we contain this patients with these symptoms and who are at risk for COVID. We also, in that temporary chest clinic, want to ensure there's strong protection for the staff. I think this is important for us to not make sure that we protect our staff, but also then have our staff actually spreading the virus amongst other patients. And then how do we manage that space and have a management approach by the facility as well in relation broadly. The third one is the district sub-district is to ensure that they make sure that staff, equipment, consumables are available, that there's some sort of support system in terms of clinical governance at a facility level, communication, and then ensuring that if we are going to need more services, expanded service contingencies, that we'll do that. So let me go through the document, and I think to be able to allow you to see what are the exact details that we are looking at doing. Sorry. So community leaders, I think, need to be involved, and we have said to the managers, please make sure that they support these community leaders with IEC material and ensure that they get that out to forums that are very important. This was actually a plan that was implemented a few days ago. So obviously in the lockdown, that is not going to be very easy. Nonetheless, we will look at how that's enhanced. The second thing is that we need community health workers to be able to get out into the community and with the kind of protection that we felt important, that surgical masks and hand sanitizers, and being able to prioritize vulnerable individuals in the community, especially the elderly, chronics, those especially with HIV, diabetes, etc. And to be able to go into the community and get them into small groups, but avoiding going into homes, considering the difficulty that they themselves are at risk. We also felt that community health workers must be very strongly linked to clinicians because of the current difficulty that there's not enough of a link to clinicians, and particularly the response team, the sort of case contact management response team. We didn't expect the virus, the pandemic to be, or the epidemic to be as quickly moving in South Africa as it has been. I think the numbers haven't come out today, but we're looking at potentially over 1,000, or potentially 200 to 300 more. The key thing in the community is that we wanted our message to be much clearer. And the message that we wanted getting out there is please don't panic. And this document, this element is in fact put together in a patient information sheet that's a little more clearly written, but essentially carries this message. And we're hoping that this will be handed out with any patient, or generally those with flu symptoms that are sent home that are not needing to be referred to the hospital or managed in the clinic any further. We want to tell patients, please remember that healthcare workers are most at risk, so don't rush into the clinics unnecessarily and allow healthcare workers to attend to those sickest. We also want to stress to patients, if they're well, what to do. And I think this is basic hygiene that we are telling them. And I think it is about getting that message very clearly to the community. We also want them to, besides avoiding handshakes, to try and look at covering themselves with a scarf, because homemade masks, because that is not so easy to get, surgical masks. Initially, we wanted to, hand them out, but there clearly isn't enough, and we need to be very careful about that number. We also wanted to tell people avoid the travel and avoid large gatherings. And if they have traveled, to call the NICD first. And that is a key challenge we had, is how do people respond to the fact that they might be at risk? And I think even now we have patients who may say, I have the flu and, I must go to the clinic because I may have COVID. We want to stress to patients, please, if you're having the flu and you have not traveled, stay at home, and if possible, get a flu pack at the clinic, which is what we've tried to arrange. I'll talk a little bit about that later. And to stress to them to sort of adopt good hygiene at home in relation to the COVID potentially in them. What we asked is that they watch for worsening symptoms if the fever doesn't settle, if there is shortness of breath and a severe weakness, and that to come to the clinic then only, and then come covered, so that they reduce risks of spread. We also wanted them to keep a record of travels. Clearly that's becoming less relevant, but still we want to encourage that because there are going to be hotspots that I think will pick up and that we need to be aware of and see if patients have come from that area. We also realized that as a public message, community message, we needed to recognize that HIV patients who have not tested are actually quite at risk. Those who are on ARTs are potentially less risky. So we said we needed to use the opportunity to tell patients that if you want to test for COVID, test for HIV. And that's kind of adopting the process we're adopting. So what we're doing in the facility is to say, well, let's set up a triage area. We've suggested people, use gazebos because they want something structured, but they keep it open, not closed, especially in this triage area. And in some of the places, they simply have, in fact, the triage staff sitting at the gate, sometimes a community health worker aiding guards, telling patients while wearing masks and having hand sanitizer, telling patients, screening patients. We have tried to encourage that they stand in a queue but 1 meter apart, whilst people are actually spraying hands with sanitizer. And we said to them, please, we're saying to them, please go with a loud hailer, especially with morning crowds, and tell patients with a loud hailer that they must ask the question, are you having the flu? And if they have the flu, to actually move out of the queue generally and to cover themselves, their faces. And then to try and talk to these patients that if they have a travel history, have difficulty breathing, or are elderly, or having any chronic disease, that they should form a third queue and become prioritized. So that third queue moves into the clinic more quickly than the others, which is simply have flu. Those who have flu can in fact be directed to the temporary, in fact, we go taking them through a triage, a second step in the triage, where professional nurse usually sitting under the gazebo, and in fact going through these patients quickly, hopefully these patients covering and themselves protected with masks, going through these patients and quickly determining if their symptoms are in fact mild, often seeing if they have any of these case criteria, those case definition criteria, those case definitions are then led to the temporary chest clinic. But we are saying to the staff at that gate, at the triage, if you have a patient that has a mild symptoms and would prefer taking a flu pack, that they take that and go returning. So we're hoping that a lot of patients just simply go home with that flu pack. What we've included in the flu pack is just Panado, some Allergex, and vitamin B Co. We've also created a version for children, and this is working fairly well at clinics already in terms of reducing the crowd and allowing us to have better social distancing within the facility itself. We've tried to emphasize that the temporary chest clinic should be fairly close to the triage area and in the clinic itself. And some clinics are setting up tents in that space, but we've said it needs to be a clinically suitable area. We've also stressed, please set up an HIV counseling and testing area near the gate as well, so that patients can be encouraged, if you want to do the test, go in there and do that. And we visited Zola and Chiawelo, and I visited them, and it seems to be working pretty well. The third thing, or the second thing in terms of the facility itself, is to designate an area as a temporary chest clinic. As I said, it needs to be clinically suitable. Whether these tents are suitable is a question. We'll have to watch and see, because it's literally a tent, almost like a functions tent on grass, and that may not be clinically suitable. But we're going to watch what is going on. What we insisted on is that there be at least one isolation room attached, and that it should be capable of larger numbers and not simply being part of an emergency or small cramped clinic, that they need to have it quite possible to manage a lot of patients who may come in with flu symptoms, and how do you separate them out, with the clinicians separating them out without confusing issues, and also allowing space for some social distancing, the meter apart. So what we've said is that firstly, all staff need to be rotated through this temporary chest clinic in week-long, because we said, that if it's every day shifts, we're going to have difficulty with spread in the rest of the clinic if any one of them actually contract COVID. But that depends on the staff compliance. Some places staff have flat out refused to work in this space, and in negotiating, some options have turned out, well, let's do daily shifts. But this has been, I think, given the public service culture, there's been some challenges in some spaces. in some of the community health centers with nursing staff refusing. So the second thing is that we want to ensure that in this space, in this temporary chest clinic, surgical masks must be worn, especially with proper technique and using hand washing in between seeing patients. We've said that we don't want people to wear N95 masks because a systematic review showed that in practice, there's no real difference between the N95 and surgical masks. And it is quite wasteful. So what we've said is that N95 masks will be worn with gloves, disposable gowns, and goggles only when taking throat swabs or if there's any other aerosolizing procedure like doing a intubation on a patient if that's needed in that isolation space or otherwise. We also said that staff in that temporary chest clinic need to monitor themselves. I think as all staff that are going through this area need to monitor themselves, and should they experience any symptoms, especially in a facility where the COVID-19 has been confirmed, that they should self-quarantine, get tests, and then self-quarantine until the results are available. And then, of course, if they're negative, then they could come back to work, but protect the others against any other viruses that they have. I think the opportunities that we want to use is that having more space would allow us to triage better. I think at the moment, with the low numbers, all that is happening at the moment in the triage is that it is being organized as part of the emergency sort of setting, where there's a small room and as an isolation space, there's not enough numbers, so people are just simply managing it like that. But if numbers grow, it is not possible. And we've said that emergency services will have to be set up where these temporary chest clinics don't just close up at the 4 o'clock, but they'll have to continue right through. And we're encouraging that they set it up now. But I think that it's got to be managed in terms of how that's able to be staffed adequately. So clinic managers have been left with that discretion as to how they do it. And I think that we've, as I said, asked for that clinicians go and view, especially CHCs, and see that the sort of way in which it's implemented is adequate. So we've also said X-rays can't be used. I think we needed to be careful about that because that will lead patients into the rest of the clinic. And generally, clinic X-rays are not actually that useful unless you have a serious patient, in which case the more important thing is to resuscitate them and get them to a hospital. But we said that if it is clinically vital, that it can be done. We don't want any, these temporary chest clinics, they must be stripped of anything and be really bare without anything but the equipment that's necessary. So we need to be very careful of the rooms that are being used. I think within the clinic, it's the temporary chest clinic, we want to emphasize the same problem. Please keep people 1 meter apart wherever patients are coming with these flu symptoms, that they need to be managed in that way. And that in that space, any patient that meets the NICD case definition, which I think is changing, the travel history is now, more, could be local travel, and one needs to be aware of that. And we suggested to them that please put that patient that you suspect as a COVID patient into an isolation room, and call the NICD or the response team. And we've got a response team that is at sub-district level in the Johannesburg Health District, and those are the names of the people. So please, this document is available. It will be sent out on the clinical clinicians group for Johannesburg. It has been sent around, so please look at those details, put them up in the clinic, and ensure you have them so that if you have a patient at any hour, you're able to deal with it. If these are challenging, where you don't get a response from the NICD or this response team, you need to proceed as a clinician to, in fact, consider the patient, whether you think there's a strong risk of COVID-19 in this patient, and do the throat swab. We've, in fact, had information provided to us that the response team has set up clinics where there will be testing done. This, as clinicians, we consider a problem, because if we send patients to go from our clinic to that clinic, they risk being lost. And we, rather that they actually get done there, and then sent back home and escorted back home with hopefully a community health worker that establishes the address. There are lots of forms that are required to be filled in, and these forms are available, and they especially include one that you look at the patient under investigation. Secondly, that you have a clear set of contacts with that patient, and that there's also a monitoring form for those who are contacts who are contacts that are asymptomatic, that you can say, listen, watch out for these symptoms. So I think that we want those forms to be dealt with, and it must not be just filled up at the clinic. There needs to be a validation of address. Otherwise, we risk having a COVID-19 patient that's identified, and then we go to the address and find that they've given us and find they are not there. And I think that's going to be a serious challenge. So really, I urge all clinicians, please make sure that that patient doesn't disappear out the door. As clinicians, we are sitting with the difficulty that we've got this patient who has respiratory symptoms, and we've got to be able to make a decision as to what we're doing with them. In terms of management, we've had a CPD meeting last week that's available, so you could use that in terms of the more explicit management of COVID-19 pneumonias. But we want to stress that if patients have a mild symptoms, they should be treated with a flu pack, and then the information sheet that is being circulated as well should be given to them, and they should be told strictly go home and self-isolate as patients with symptoms. So in that respect, please make sure you get this information sheet. ANOVA is in fact making copies of this information sheet, and we hope that they'll be available at all clinics, and you could in fact have copies available to give them. That is what should be happening, in fact, at the front gate. So at the triage area with the clinician, they should be dealing with this, and you shouldn't be seeing any of these mild patients with the flu. What you need to be seeing is patients that might fit the case definition, and in which case you need to go through that using the sort of screening tool that we've also circulated. So go through the case definition and make sure that these patients, if they do fit the case definition, are then investigated. Don't forget that if you have patients with signs of pneumonia, severe symptoms, that you're not just managing COVID, you're managing a whole bunch of other diseases, including atypical pneumonias, TB, etc. So we want you to investigate and think broadly. Please treat for atypical pneumonia using these drugs. These are the drugs that are recommended in the NICD guidelines. Please avoid any prednisone. And of course, if you need to do the NICD swab, just consider that. If you're going to send home and this patient's not very stressed, the big question is going to be, is this patient decompensating because of the pneumonia? And it's very difficult to make that decision based on cyanosis. You're going to have to use SATS machines. And as a guide, if a patient's below 93, based on WHO guidelines as well as Chinese guidelines, the UK has 94%. You need to say this patient here can either get a short period, an hour or two of oxygen to see how they're doing. If they recover quite well, you might consider sending them home. But if they're not and they're still at below 93, 94, you're going to have to send them to hospital. And I think that please be aware that on the side of caution, at the moment, some of these patients that may seem like they are responding well may decompensate quite quickly and at home and come in dead. So I think please be very careful. So if you're at all worried and if you have SATs below 95%, please consider referring them to the hospital if they look distressed. In terms of referral, initially when we set out this guideline, it was referrals to Charlotte Muteke, but I think that we are going to have to send to the nearest hospital. So at the moment, Beki, Mlangeni, and possibly Krisani Barra are your two hospitals of referral. The usual approach is going to operate that you will have to call in and discuss it with a clinician there. Please don't just send patients via their cars through to that place. So please call the ambulance. The ambulance service is sensitized to this and should be responding. You also have those numbers if you need for all clinicians or are needing any sort of support from the NICD. from a clinical point of view, call those. There are also some other lines that we've put on now that you might use, call for doctors who will circulate those numbers so that you could use them to get some sort of clinical support. You also can join the VULA app on your little mobile. Please use that. You should see our names on it available for any referrals, but specifically the hospitals should be there and you should be able to refer. We'll send out details of the VULA app shortly. Importantly, that you are not going to be able to have these patients going and fetching their normal files. So you're going to have to ensure that there's some admin person there who is in fact making records, issuing records there, allowing you to keep records, and that these are kept there within the facility with copies of your documents, especially the PUIs that you are needing to fill in and all the documentation related to that. We want to make sure that this space, this chest clinic, is well managed as a self-contained area where everything you need can be functioned. There are obviously going to be patients who are coming in with more than just chest symptoms, saying, I want to collect my family planning as well, or I need hypertension medication, and I thought I'd come in as well. So you're going to have to make sure that in that chest clinic, you have whatever it is that you need, and that it is managed well enough to avoid a patient needing to go anywhere else. So we don't want staff generally to waltz in, waltz out, as managers tend to do. They need to wear protection, and I think we've talked about the protection that needs to be worn, at least a face mask. We also have said that this temperature chest clinic needs to be sectioned, especially for dealing with cleaners. This could be done in whatever way needed. It might not need the two sections, but what we need is that those cleaners clean properly. And in fact, we've insisted that there should be 3-hourly cleaning going on in that space where they are protected themselves, and that they use all disposable type of material, and that they clean all this kind of stuff that is used in that space, including blood pressure monitors, and anything that is not that is reusable be clean, but anything else be disposed of, and being very wary of waste management, medical waste management. And I think that they should in fact discard everything appropriately, and then be careful to protect themselves. So the details are all in that. We've also said that in the facility itself, they need to have this approach to this process overall well managed. And so the facility managers themselves shouldn't delegate to an infection control officer and leave that to somebody else. They need to take it on themselves, making sure they bring at least a doctor, community health worker, and a clinic committee member into that so that they can coordinate this response very well. And we said to them they need to keep minutes of their meeting. We said in this plan that they need to allocate a person operationally to be responsible for this arrangement. Often people tend to say, oh, I didn't know this and I didn't know that. And they need to have someone that is going to know exactly what's going on. It might be the facility manager, then they think that's what's happening. But other than that, if she doesn't have her hands on, she needs to make sure somebody has their hands on this thing. So I think that we also are very concerned that staff generally across the clinic may get very uncomfortable. And we've said that facility managers need to debrief their staff weekly, give them a sense of what's going on, particularly in relation to what cases have been identified, what's happening in terms of the process, and also to emphasize the infection control. I think that many people are not aware that the biggest space for transmission of this disease is going to be clinics, because those people are sick. There's lots of crowding, and I think we're going to be the real problem if we are not going to be very aware and manage these spaces very well. We are the only place in the world, in the country, that's going to allow numbers of people together. So allowing staff to wear surgical masks, but we actually said that staff generally wearing masks is actually not very helpful. And I think that we need those surgical masks for people who are in the chest clinic. We thought we'd give masks to patients, but in fact, we ought to be giving those masks and turning them over and giving it to the masks of patients that are sitting in that chest clinic. But at the moment, we've said to patients to say, considering this lack of surgical masks, that they should simply cover their mouth with either their shirts or some sort of scarf, etc. but really we need to beware of the lack of protection material. There's a systematic review that is in fact referenced in this document that shows that there is really no benefit in the real world of wearing an N95 as opposed to surgical masks. We said that we do want staff generally to be very aware of case definition, case management, because you might find suddenly patients coughing in all sorts of places that they shouldn't be and somehow slip through the cracks. And we need staff to be very, very aware of patients around in the clinic and be able to ask questions and direct them back to the chest clinic. We said that we want to make sure the clinic is arranging posters, patient education, hand washing everywhere. Social distancing as well in the clinic and CHC itself is very important. So we really stressed that people must be sitting apart. It's just surprising, even up to yesterday, that in the clinics, people are just crowded and standing next to each other with no idea of the risk that they're putting each other in. We've said to the facility, please get going with getting elderly and chronic, anyone at risk, to start taking the flu vaccine. It just arrived just literally about 3 days ago, and we hope that this is already being used for patients, especially the elderly in the chronic clinics. We also have tried to get the patient numbers reduced and have encouraged all patients who are chronic stable to get their 6 months medicines dispensed or referred to the CCMDD or whatever avenues, but make sure these patients, if they're stable, don't come every 2 months, unnecessarily to the clinic. So we've just tried to encourage them. So you need to explore within your clinic what's possible with the pharmacy or the facility manager and stretch out your next visit as much as possible. I think that in the clinic itself, we really worried about emergency equipment, and we've said that the emergency trolley needs to be equipped. It needs to be even a separate trolley kept in that isolation room in the chest clinic with basic stuff that's required for intubation, including some drugs. And that might be a patient that's suddenly decompensating. We need to be able to manage that immediately. We're also worried about security at the gates and in emergency, and have said that the facilities need to be aware of security and make sure that they're procuring whatever they need to. And then also at the facility level, that they have a community response team for cases and contact management, because that's going to be a key element as we go forward. So we also said the facility needs to make sure that the team leaders and the community of workers are consistent in training community on infection control. At this point in time, it'll have to be done mostly in the facility itself across the entire facility. We thought we'd get IEC material out for community campaigns. I imagine we can find ways in which we can still get that material out. And we suggested at facility level that they do drills under different scenarios, considering the options that we have of different scenarios possible as we're going forward. So this is the kind of facility level plan that is being held, and I think that we hope that this document will prepare the facility manager to be able to do this and succeed in managing the sort of primary health care interface. So at a sub-district level, we've actually said that sub-district managers need to really make sure, because facility managers are battling with having some of this material immediately available. And we've set out a whole bundle of little things that we think really important to be available, and have begun taking surveys in the facilities using a tool that we circulated as well. Do you have these? Are you battling? And then that hopefully that survey will help us pick up where the challenges lie. And then the sub-district could in fact make sure these are available immediately. So we hope that facility managers will reach out to their sub-district managers and fill in these, while sub-district managers ensuring that stocks are available and being specific about what's required. I think we've included some things there that are not specified, like SATS machines and intubation equipment, etc. So at a sub-district level for the clinical governance team, which is really the family physicians, DCST, including the senior managers at sub-district level, we said we needed to review plans. A plan was actually put together a few days ago, and see where they're going. We said we needed to make sure that we have involvement of the district public health unit and this response team management team at a district level with us. We have a weekly meeting online now. We had one yesterday, and we're hoping that we can use this online meeting as a clinical governance team to pick up what's going on broadly and be able to pick up challenges in terms of this plan's implementation. We do know that as we're going along, EMS and the referrals are going to be refined. We're going to have to consider what are we doing if the if the numbers continue and we start having the kind of pattern of morbidity and mortality, we are going to have to understand that numbers are going to be driven up at the hospitals. We also said that we needed to prioritize the education for focus on old age homes and be able to get these things like an infection control officer put together. So these are this plan is in fact literally signed off about a week ago, and it's dated already. We also said at the district level that there needs to be an approach to local radio, that it was felt that that is a very useful opportunity with billboards and the other. I think this is still looking very wanting in the district, and from a national point of view, I can't imagine why there isn't much more happening in this regard. But anyway, I think that the other thing that we said at the district level was really a critical problem was staff shortages, especially if we had 24-hour facilities currently having a double shift. That would be literally doubling every 24-hour facility, and that would be really quite impossible. So we also allowed the fact that some of these 24-hour emergency services would be have to close down, where these people would be moved to a current one, and then allowing the doubling up to create separate chest clinics running 24 hours and managing, containing COVID patients from others. We also have the notion that as we're going along, we need these treatment sites where patients who are perhaps needing admission would be sent to these two sites for starters. Lens South is immediately available. And so if you're referring, consider that, call them first and ask if they can be admitted. We've asked for Barra to, in fact, work with us visiting the site to see patients and to refine the way in which patients are managed there and which patients might need to be referred up to Barra for ICU beds, etc. And I think that we will have to play it by ear as we're going along. There's also going to be social quarantining that's necessary, or even social isolation, depending on the patient load that we're getting, that we're going to have to say, where are these patients who really should be going back home, but they're going back into a crowded family of 30. And we need to be able to consider that option. And I think that's what the district's going to have to look at, depending on how we're moving forward. So whether there are halls, churches, mobile clinics to create chest clinics, or mosques, etc., these are actually all the kinds of things that we are going to have to put up. So in terms of going forward, I'm not sure that there are any questions, but if you would like to just fill in this poll, and we can pick up while people are thinking about whether they have any questions to ask, or if they would like to speak as well, we can allow that. All you need to do is, in fact, just indicate that on the question and answer, and we could sort of just post your questions on the Q&A. And if you want to get your way around, if you see the screen, just move your mouse over the screen, and you should see your menu bar popping up at the bottom, and you can see the Q&A at the bottom, allowing you to put out questions. So for those who seem to be joining us at this late hour, I'm going to just go through the summary of what I've just said, that we as Johannesburg are planning to implement a plan to contain and manage COVID patients in the community at a primary care level using 3 approaches. One is dealing with the community. 2 is being able to do things and the community being from the facility itself. And then what do facility managers do in the facility itself? And then what do sub-district managers do to support these facilities? And the process is, the key elements of it are that at the community level, that we try to deploy community health workers into the community, engage with key stakeholders in the community so that they are part of our planning and process, and that we have a consistent, clear message, which we have circulated in the clinicians WhatsApp group for Joburg as a patient information message. And I think this, we hope, can be given to all patients and used. I think it's a little, we're hoping that Aniva can provide that patient information sheet to you. So tell your facility manager to contact Aniva and to talk to Tobela. I'll send his name on the message just now from Aniva at a district level, that will be able to provide them the copies. The second thing is, at facility level, we want the facilities to set up a triage area, which should be able to sort out patients and possibly treat patients right there with mild flu symptoms, giving them a flu pack and sending them back out home with a clear information sheet so that they follow instructions very clearly, because every person with a flu is potentially a COVID patient, but we cannot treat them, manage them anymore, and there's no need to test immediately. I think that we have to just consider that option. Right now, the case definition does require us, and so follow the case definition, even in managing those patients with flu symptoms, mild flu symptoms. If they fulfill the case definition, then they should be sent to the temporary chest clinic. So those people who are in that chest clinic will have to make sure they're well protected, having all the gear, which is really just a face mask for now in managing the patient. But should they have any patient that they suspect as having COVID, they will have to put them in an isolation room. And that isolation room needs to be well equipped with the equipment they need, including a pack for the testing, as well as goggles, gloves, N95 mask, disposable gown. Please make sure you use that, have a good protection, and then you need to refer as appropriately. In addition to that, the facility needs to have the management of the entire facility kept in mind, and the details are in this document. We also said that the district needs to support that in terms of going forward. So I have about 6 questions. Thank you to those who have provided these questions. Fatima P says, where can we get copy of the discussed plan? I will, I'm not sure that I can send it now on this group, but I will just give you the website shortly. Give me a second, and I'll put it in. But it is on the website profmoosa.com. It's also on the, just get this quickly. So it is there, but I'll give you the thing shortly. So I'll send it to you shortly. Isaac Mita asks, you mentioned that travel history will be obtained at triage with confirmed internal transmission. Is this still emphasized? It does not, it's not a necessary condition. So if you look at the PPE the case definition requirements, it basically says any symptoms of flu, even mild, and any one of those other conditions. So it can be that they have a patient that is having traveled to some place that is local, and that could be anywhere perhaps in Joburg, but I think it's not necessary condition. So if there are other elements of it, in other words, that they have a severe pneumonia, that's a case definition. So I'll give that as well just now in the answers. So give me a few seconds and I'll put out the case definition again in this group. I think Yogan Pillay has advised that WHO CDC says that healthcare workers wear N95 masks and suspected or infected patients wear surgical masks. They advise that surgical masks do not offer protection against the virus. I think, Yogan, the challenge is, and I think as a senior member of the Department of Health, our biggest challenge is the availability of it. I think, I'm more than sure that when we looked at the number of N95 masks in clinics in Soweto, they said they don't have very many. And in fact, they're battling with surgical masks. I think this is something that if there's ways in which you can we can actually support people on the ground, there's challenges. I think people need to be able to send that message to you. We welcome the advice. We've certainly implemented, but this comes from managers on the ground that they say they don't have it available. So we will try and I think we'll take note of that and make raise our concerns. So thank you, Rogan, for that comment. I think please email the information sheets. I will also give you just now in this message the link. All of the stuff is on the same page, website. What is the plan for complicated cases, Yogan asked, and when there are no more ventilators available? I think the question is something we're going to find very difficult to answer at a primary healthcare level, Yogan. I think the challenge we have is the capacity of hospitals to manage. At the moment, even the case definition, we're going to have difficulty if at the current moment in Johannesburg with the confusion, where they're saying there are centers and are not supporting us with facilities having the testing kit, we're going to be sending even normal patients to other places. And we don't want to do that. So if it is a complicated patient, at the moment, when you say complicated, I find even a patient I can't do a COVID on that I suspect is to me a complicated patient, I'm going to send them to the hospital. And I think that's what any doctor reasonably is going to say, that's what I should do. I think that the hospitals we are in communication with, and the option is for us to say, like I mentioned earlier, that if the patient can be admitted to Lens South Hospital, which has been cleared out to be available, we could actually send them there. Obviously, if a patient needs ICU instantly and we are intubating the patient, Lens South cannot take them. We'll have to send them through to Barra. That's for Johannesburg. That's for Soweto. I think that would be very similar to other places. In fact, for the whole of Johannesburg, there are only 2 sites that are available for arranged by the district. That's Discoveries, which is in Rudaport, and Lens South, which is in fact beyond Lens in Asia, for the entire bit of Johannesburg. In terms of district hospital, as first port of call for patients complicated, it will be South Rand, which is potential for region EF, or Edenvale potentially, or in fact, Bekim Langeni. But if there's a patient needing admission, all of them will land up in the 3 main hospitals, which is Charlotte Maxeke, Helen Joseph, and Barra. And I think complicated would be anyone intubated or looking very precarious that is going to decompensate quite quickly. I think when there are no more ventilators available, I think that's the tragedy we're going to all see. Patients will die. Belinda Richard, thank you. The primary care physicians will probably be an important triage component. Are there guidelines or protocols to be shared with the private sector in terms of engaging with the district? I think that we've opened this call up to any clinicians in Johannesburg. So potentially any private sector doctor who is seeing a patient and has fulfilled all the criteria of case definition, welcome to call those avenues, and we'll put them out very clearly, those opportunities to send patients through to Discoverers. And you can, and I'll put that number out on the website, Discoverers, Lens South, Bekim Langeni, South Rand Hospital, Edenvale Hospital, if you have a patient. CHCs may have the capacity, so there are 11 CHCs in Joburg, and CHCs, and I think most CHCs will be available, having oxygen available. I'm not sure. We've actually suggested that all clinics have oxygen available and could administer oxygen as a temporary measure. But I don't think intubation is going to happen anywhere but potentially a community health center, and that too as a last resort after trying out and before, hopefully that we refer the patient, admit the patient by ambulance, transferring them, and not have a problem that they suddenly crash. So our suggestion to the private sector is please be very careful. Don't send them pillar to post. That might actually kill them. So look at the patient, make an assessment. Those are the 2 options, those 5 or 6 facilities in Johannesburg, hospital facilities or the main hospital facilities if you need ICU care. I think if this changes, and it may very well change very quickly, where the capacity is, choked up, we will let you know. So please join the WhatsApp group. I will put it into the post that I'm going to include in that post I'm going to put out. So it's one post which is available. Sorry, I'm trying to navigate my my desktop. Being alone, sorry. So let's see how I can get to that. I need that window up and in fact get to this so that you can get this information quite quickly. Okay, if you go to profmoosa.com, I'm going to suggest that you look at COVID Resources South Africa, and I'll post that. And you'll see all the stuff going to be at the bottom on a list of documents. All these things are available, so I'll just post that there now for all of you. It will answer all the questions about the plan being available and other documents. The information sheet I'll post up there as well. So let me go through asking the other questions. Excuse me. The case definition I'll also post up there so you can see that. So I'm a dentist, and what recommendations broadly and specifically as we create aerosolizing, I think you do need to be aware. I would strongly advise that you look at any elective procedures and defer them. And otherwise, use strict PPE with N95 masks. I think otherwise you are risking a challenge in terms of picking up COVID. So, and I'd strongly consider just deferring things along. I think one needs to just look at the kinds of procedures that you need to perform. So Belinda Richards asked are there any guidelines in terms, sorry, we've just answered that live. Let me just again emphasize the availability of the documents that you can get. We are test kits, Dr. Mpatlele asked, found a facility still giving Brufen, just reinforce it should be removed. Please, if you find, please go looking at the flu packs. If they have Brufen, they should be taken out. We've actually said they should not be having Brufen. We also see that people are not sticking to that 1 meter apart. Please, as doctors, go around, try to check on patients, tell people, whoever are standing around, clerks, etc., to keep that in shape and make sure that is happening. Put up posters, as Dr. Mpatlele has suggested. Please talk to the manager, your facility manager, about testing kits. You need to make sure that they are available, at least 3 or 4 or 5 in that isolation room somewhere. And you should be asking the facility manager, where is your isolation room? What are you having in it? And look and see what gaps. We've said those isolation rooms need to have all the right PPE, testing equipment, emergency equipment. And the emergency equipment, intubation, what you require, both drugs and equipment. So go looking at it, asking the question today to the facility manager, make sure you're all equipped. I think you're going to be very key in terms, as clinicians, in terms of ensuring that's available. That the facility manager ought to speak to NHLS or NICD about the testing kits. Make sure the testing kits has all the forms and everything together with it so that you don't have to go rushing around looking for everything. Rather make sure it's all in hand now than rushing around at the worst of hours. So please do that. I think what support will be given to facilities housing mentally and physically disabled people. I think this is part of the challenge I've raised, that community health workers have to be on board. They are going to have to deal with individual patients. They know these patients, they should know these patients. And if not, we should be sending messages out for them to be reaching out to community health workers. And at a facility level, I urge you to raise that with the facility manager, tell them what is going on. Are the community health workers, do they have a list of these kinds of patients? In Shawelo, we've actually developed that list for the wards around us, and we highlighted that these patients are vulnerable patients and the community health workers need to support them. They obviously need to use protection, but they need support. These patients can't be left out on their own. I know that there is a chat, a hand up, and I'm trying to get a way to answer that question and find that way to get the person to do it. I'm sure that we've seen who's around in the poll. I'm not going to close that right now, so if you come in, fill up that poll. I think that is done. Richard Cook, thank you very much. You're saying, discussion point, any flu symptoms, even mild plus, usefulness and practicality of using reviewing the triage tool to include open-ended questions in attempting to differentiate, can we, I think those questions are going to be challenging. We have a lot of anecdotal information right now, and at the point at which this plan was organized, we in fact did not want to include things that are controversial. So we've kept it really simple, following NIC guideline very closely. We have set up a tool that Dr. Tuluta has set up with the question of having a register for patients as they're being seen in the chest clinic to ask about comorbidity, etc. But what you're suggesting is, do we ask about symptoms that are considered, you might say, the ones that are being raised, like anosmia, etc. I think these might help us to pick up disease. I think these are useful research projects. Our problem is to try and do that effectively. So I think we hope that Dr. Tuluta is on board, and I'd strongly advise that we reach out to her and speak to her. So if you have any suggestions on how we could improve that tool, please reach out to Dr. Tuluta from the district. I'll have to send you an email, but that's another story. Is it possible to get a video to listen again? Yes. Just watch your email. That'll come to you in a day or so. Otherwise, come to this website, profmoosa.com, and you should see that available. Anonymous attendee, any dental emergency involves blood during removal of tooth and drilling to remove broken tooth. I think this is routine. Is PPE sufficient? I think yes, if you're using all the requirements of protection, and I think that using a glove, eye goggles or screen masks and N95 mask and a gown, I don't think that you're completely safe. So I think you should just think about whether it's necessary. If it's emergency, please don't make patients suffer. So thank you for that. Let me see if I can get those hands raised somehow. Let me stop the sharing and see if that helps me to get the hands raised helped. So, yeah, I think, I'm not sure I'm seeing that anymore, but nonetheless, I'll go to the last two questions. Mimi Jordan, sorry, Mimi, I couldn't use your hand, address your hand. Can patients be sent to Discovery without arranging a doctor accepting them first? I'm afraid right now, I don't know that. I would suggest strongly that we do contact them. I will put up the details of Lens South Discovery, the details of how to contact, who to contact, or if you don't need to contact on that poster that I've put up now. Are they arranged for more than one for the 24-1 doctor at these facilities? I think we are challenged at the moment. We're going to have to keep a tab on it. It is functioning at the moment as it is. It's based on what is happening right now. I think Mimi also asked, are there guidelines for sterilizing laryngoscope blades? I think the usual sterilization expectations are going to follow. The facility managers, and please, I would urge all of you to go check that and raise it to the facility that what is their turnaround times for sterilizing, and that they need to keep sufficient numbers of laryngoscope blades, etc. I think these are very difficult questions to answer without knowing the trajectory of cases. And yes, we can actually ask for a lot, and I think we're trying to do that. I think we just need some sort of close management. So I think these are very valid points. Thank you all very much for raising them. I think we've answered all the questions that are available. As I've said earlier, thank you to all the people. We've had spread of specialists and medical officers, doctors, some professional nurses and PHC nurses and managers. I really appreciate it. We'd really hope that PHC nurses and professional nurses join this. I think that it is very important that we all keep a handle on it. It is going to be a weekly CPD meeting that's going to be run, and in which we are going to try to do general CPD and just throw in a few words about what's happening with this COVID so that people can keep abreast. And I'm really pleased that we have a spread of people from all across Johannesburg and even outside Johannesburg. So with that, let me just double check that I haven't missed anyone. So with that, I'll just share the results. You can see now who have been attending this teleconference, the Zoom meeting. And I think if there are no other things, Jürgen Pillay is not the Jürgen Pillay, so sorry about that. So in the chat group, sorry, I haven't been able to keep up with the chat group, but are there slides available? Will there be change in data definition? What guidelines? I think most of these questions. So yes, I think we'll put out this information on that website, and you will have all these questions answered. So please take the website that we've just put out, go to that web page, and everything you've asked for will be there in about an hour. With that, thank you all very much. Enjoy your day. Be safe. Keep safe. Take care.